ones appearing in red are the ones which will be covered in this video cast. The last two will be covered in part 2. The spinal cord is perfused by 2 posterior spinal arteries and 1 anterior spinal artery. The anterior spinal artery provides about 75% of the total blood flow to the spinal cord. The anterior spinal artery begins as a fusion of vertebral arteries, reinforced with 6 to 8 radicular arteries, the largest of which is the artery of Adamkiewicz. In 75% of patients, the artery of Adamkiewicz results from the fusion of radicular arteries from T9 to T12, but the range may go from T5 to L5. This configuration, which includes the general absence of collateral circulation, leaves the portions of the spinal cord perfused by the anterior spinal artery at risk for ischemia in the event of the disruption of blood flow through the anterior spinal artery. Anterior spinal artery syndrome, the combination of manifestations which occur as a result of compromised blood flow through the anterior spinal artery, presents as flaccid paralysis, loss of bowel and bladder function, but intact sensation and proprioception. This table presents data regarding the risk of anterior spinal artery syndrome associated with various surgical procedures. The risk associated with endovascular procedures is unclear. Questions regarding this content are commonly presented as a clinical scenario in which a patient underwent a surgical procedure associated with the risk of anterior spinal artery syndrome and also had an epidural placed. The issue is to determine the etiology of the patient's problems. The history alone is generally sufficient to rule in or rule out an epidural abscess. The ability to answer the question requires knowledge of the manifestations of anterior spinal artery syndrome. For example, the reflexes and sensation remain intact. The absence of back pain is another clue to the etiology. Although currently performed essentially only in infants, in the past, caudals have been used for surgical anesthesia for procedures such as hemorrhoidectomies, DNCs, and TURPs. Remember that the caudal is simply a different point of entry for the injection of local anesthetics into the epidural space. Here's an image demonstrating the relevant anatomic structures for performing a caudal anesthetic. The 2 most important structures for locating the sacral hiatus are the sacral cornu. One of the reasons caudal anesthesia has fallen into disfavor in adults relates to the high degree of variability in sacral anatomy. In children, it is important to recognize that the presence of a sacral dimple indicates the anatomy is not normal, and that the presence of the dimple may be associated with spina bifida. The objective is to place the needle through the sacral hiatus and inject local anesthetic into the epidural space. Most people advocate that you start with the needle positioned at a 45-degree angle and then flatten it out after you feel the pop, indicating that you've entered the epidural space. As shown here, the sacral hiatus forms one point of an equilateral triangle, for which the other 2 angles are the posterior superior iliac spines. Incorrect needle positioning includes placement in the dural sac, the periosteum, and the soft tissues above the sacrum. As shown on this slide, the needle may also be intraosseous. The slide also documents some anatomic variations in the sacral hiatus, including the fact that it may be closed. One thing commonly recommended, and which could be the basis for a question, is that the application of pressure over the midline may allow detection of a subcutaneous injection. The last concept, which I doubt will be the focus of the question, is that the distance from the skin to the caudal epidural space correlates best with patient weight. The most logical question for issues regarding the anatomy of the dural sac probably relate to the differences between the caudal extent of the dural sac in adults and children. In adults, the spinal cord ends at about the level of L1 or L2, and the dural sac extends to the level of about S1 or S2. In infants, the dural sac extends to about S3 or S4. The end of the spinal cord is located at about L3 in infants and does not reach the normal adult level until 1 year of age. Notice also that the spinal cord and dural sac are much more of a straight shot from the sacral hiatus in a child compared to an adult. This means that dural puncture is more likely in an infant than in an adult when performing a caudal anesthetic. There are at least 2 approaches to this key word: the anatomy of the epidural space and the anatomy involved in performing an epidural. The former relates solely to the space itself, while the latter would relate to those structures traversed by a needle during the performance of an epidural. Historically, a favorite question regarding the anatomy when performing the epidural is to inquire about the structures encountered by the needle, especially the sequence in which they are encountered. After passing through the skin, the next structure encountered is the superficial tissues, consisting mostly of subcutaneous fat. That is followed by the supraspinous ligament, the intraspinous ligament, and the ligamentum flavum, before encountering the epidural space. Recognize that on occasion it is possible to inject a dose intended for the epidural space into the subdural space, which is deep to the epidural space but superficial to the subarachnoid space. If a subdural injection occurs, no CSF will return from the needle, but the anesthesia will be much more widespread than if the injection had occurred in the epidural space. Another possible question would relate to structures which form the boundaries for the epidural space. The anterior border of the space is the posterior longitudinal ligament. The posterior border is the ligamentum flavum. Fusion of the spinal and periosteal layers of the dura at the foramen magnum delineate the cranial extent of the epidural space. As previously discussed under the section on caudal anesthesia, the sacrococcygeal membrane constitutes the caudal extension of the space. Laterally, the space is limited by the pedicles and the intervertebral foramina. The epidural space contains fat, the dural sac, spinal nerves, and blood vessels. Venous drainage is valvuleless, and the veins are predominantly located anteriorly. The posterior venous plexus varies in size, but is generally larger in the thoracic and cervical areas. Increased intrathoracic or intra-abdominal pressure may result in venous congestion in the epidural veins. The paramedian approach to both subarachnoid and epidural anesthesia has been touted as being superior in elderly patients with degenerative changes in the spine. Hypothetically, at least, the structures involved in the paramedian approach are less likely to be affected by osteoarthritis. Some studies report the use of the paramedian approach results in faster catheter insertion for continuous spinal and fewer attempts at needle insertion. Another advantage is that flexion of the spine is not necessary for the paramedian approach. Needle positioning for the paramedian approach is described as follows. After palpating the interspinous space between 2 spinous processes, needle insertion should be 1 centimeter lateral to the midline. The needle should be located at the cephalad border of the inferior spinous process. The needle should be at a 10 to 15 degree angle from the midline and pointed slightly cephalad, often described as a 70 to 80 degree angle from the skin. If the needle contacts bone, it is most likely the vertebral lamina. As the needle is walked off the lamina, the angle may need to be changed to as much as 45 degrees cephalad. With a midline approach, the needle passes through the skin and subcutaneous tissue before encountering the supraspinous ligament. It then encounters the interspinous ligament, the ligamentum flavum, the epidural space, the dura, the subdural space, and the arachnoid membrane before entering the subarachnoid space. With the paramedian approach, both the supraspinous ligament and the interspinous ligament are avoided, but the needle will traverse some muscle. This is the end of this video cast. I hope it proves useful to you in preparing for the exam. This is part 2 of my video cast to address keywords and phrases relating to diabetes. These are the keywords related to diabetes from multiple years of ITE reports. The phrases that are crossed out were addressed in part 1. The phrase in red, diabetes and stiff joint syndrome, was a new item in 2017. The first issue is autonomic neuropathy. Autonomic neuropathy has a multitude of manifestations. It may be worthwhile to pause the presentation here to review this slide in greater detail. My discussion will focus primarily on the cardiovascular manifestations associated with autonomic neuropathy. Symptomatic autonomic neuropathy occurs in only about 5% of patients with diabetes. Resting tachycardia and loss of heart rate variability during sleep are some of the earliest signs. Both systolic and diastolic dysfunction are associated with autonomic neuropathy. Baroreceptor function is compromised in the presence of autonomic neuropathy. This occurs due to damaged vasoconstrictor fibers and ineffective cardiovascular reactivity. Orthostatic changes in blood pressure and heart rate are another indicator of cardiovascular autonomic neuropathy. Also, failure of heart rate to respond to exercise is indicative of significant cardiac innervation and is probably associated with decreased exercise tolerance. Finally, autonomic neuropathy is associated with dysrhythmias that may be responsible for sudden death. Although they aren't cardiovascular manifestations, it's interesting to note that both oxygen and carbon dioxide response curves are altered in the presence of autonomic neuropathy. This may have ramifications in attempting to reestablish spontaneous ventilation at the end of a general anesthetic and postoperative respiratory depression, especially following the administration of opioids in the PACU or on the floor. Other than the central nervous system manifestations, hypoglycemia is probably most easily understood as a cause of an adrenergic syndrome. This slide correlates the manifestations of hypoglycemia with specific blood glucose levels. Again, it may be worthwhile pausing the presentation here to review the slide in more detail. Note that the values for blood glucose are in millimoles per liter. To convert that to milligrams per deciliter, multiply by 18. CNS manifestations of hypoglycemia include confusion, fatigue, headache, somnolence, dementia, diplopia, visual loss, and convulsions or coma. Cardiovascular manifestations include tachycardia, palpitations, increased myocardial contractility, increased myocardial work, and vasodilation. Increased myocardial work may lead to ST segment depression. ECG manifestations include ventricular tachycardia, atrial fibrillation, prolongation of the QT interval, corrected QT interval, flattened T waves, and ST segment depression. Hypoglycemia can also result in increased factor VII, platelet activation, and neutrophil activation. Increased oxygen consumption and diaphoresis are common manifestations of hypoglycemia. The next key phrase relates to glucagon and hypoglycemia. Severe hypoglycemia is defined as an episode that the patient cannot manage alone. That is, an episode where someone else needs to intervene. This graph shows that patients with type 1 diabetes average approximately 1 severe hypoglycemic episode per year. Although apparently less common, severe hypoglycemia is still a problem for patients with type 2 diabetes. This graph demonstrates the efficacy of both IM and IV glucagon in treating hypoglycemia. Note that the glucagon is administered at time 0. It is obviously effective very shortly after administration, whether given IM, IV, or sub-Q, so it's a reasonable approach for a patient with severe hypoglycemia who does not have vascular access. Recognize that glucagon has effects other than simply increasing the patient's blood glucose. A patient with coronary artery disease might not tolerate the increase in myocardial oxygen demand that occurs as a result of the increase in heart rate and contractility following glucagon administration. Although metformin is associated with the development of metabolic acidosis, this is generally associated with toxicity. patients with diabetes as any other patient population. Diabetes accounts for over 40% of patients with renal failure. One thing to keep in mind is that the risk of severe hypoglycemia increases with decreasing renal function. This slide shows the natural history of renal disease in the presence of type 2 diabetes. In most patients, microalbuminuria is present at the time of diagnosis. Even with reasonable management, frank proteinuria and increasing serum creatinine levels are evident about 12 years after diagnosis. End-stage renal disease begins to appear about 15 years after diagnosis. Diabetic nephropathy is characterized by persistent albuminuria, usually defined as greater than 300 milligrams per day, that is present on at least 2 occasions separated by 3 to 6 months. Progressive decline in glomerular filtration rate and elevated blood pressure. It occurs with both type 1 and type 2 diabetes, and evidence suggests that effective treatment of diabetes delays or prevents the development of diabetic nephropathy. This slide shows the most prominent nephrotoxic agents and where they have their effect. For our purposes, the primary agents of concern are antibiotics, specifically aminoglycosides, vancomycin, and cephalosporins, iodinated radiocontrast agents, which, as stated previously, are rarely, if ever, used anymore, and non-steroidal anti-inflammatory drugs. Chemotherapeutic agents, especially cisplatin, methotrexate, and nitrosoureas, are not ones we administer, but have a significant impact on renal function. With the exception of methoxyfluorine, which is no longer used, metabolism of volatile anesthetic agents to inorganic fluoride is not a problem with regard to renal function. In patients with diabetes, hypovolemia is a risk factor for the development of renal failure. Based on that, patients with diabetes undergoing any surgical procedure associated with significant blood loss, such as aortic surgery, trauma, or liver transplantation, are at increased risk for postoperative renal dysfunction. Essentially, no intra-op interventions, other than maintenance of normal volemia and avoidance of nephrotoxic agents, reduce the risk. Another factor to consider, and it could easily be the subject of a question, is the management of oral hypoglycemic agents in patients with renal dysfunction. I apologize for this busy slide, but it does provide a cohesive summary. On the horizontal axis is glomerular filtration rate divided into ranges. On the vertical axis is a list of drugs or categories of drugs. For each drug, there is an area of GFR for which the drug is considered safe, indicated by the dark gray areas. Some drugs are not recommended at all below a certain GFR, as indicated by the lighter gray. As indicated by the bars with diagonal stripes, for some drugs there is a range of GFR for which they can be used with caution, but generally at a reduced dose. As indicated by bars filled with small circles, some drugs are considered absolutely contraindicated below a certain GFR. This graph can be slightly simplified by realizing that for most drugs, the point at which recommendations change is a GFR of approximately 50 milliliters per minute. Further restrictions occur at a GFR of approximately 30 milliliters per minute. These generalizations aren't precise, but they are probably close enough to be able to answer a question on the test. It is also potentially important to remember that dosing recommendations for only one drug do not change as renal function deteriorates. Diabetic peripheral neuropathy is present in 10 to 20% of patients with diabetes. It typically has an insidious onset and is worse at night. By definition, symptoms are primarily peripheral in distribution, and they are most commonly symmetrical. Diabetic neuropathy is generally attributed to disease in the vessels supplying the nerves and affects both myelinated and demyelinated fibers. The diagnosis of diabetic peripheral neuropathy should be made based on the history and physical exam, specifically assessment of vibration, pinprick, touch, and proprioception. Motor nerve conduction studies may be abnormal in a small subset of patients with large fiber neuropathies, but are not recommended for diagnosis or follow-up in the majority of patients with diabetic peripheral neuropathy. Stiff joint syndrome is also termed diabetic scleroderma, chiroarthropathy, or diabetic stiff hands syndrome. It is described as being present in up to 40 to 50% of patients with type 1 diabetes, but may also be seen in patients with type 2 diabetes. The prevalence increases with the duration of the disease. Flexion contractures of the fingers may be present. Screening for stiff joint syndrome is done by looking for the prayer sign. Normally, as shown here, subjects are able to press their palms together. Patients with stiff joint syndrome are unable to press their palms together, so a gap remains between the opposed fingers and palms. This is obviously an abnormal exam. The abnormality is described as being due to sclerosis of tendon sheaths and limited joint range of motion, in addition to the previously mentioned flexion contractures of fingers. Some improvement in joint mobility over time may be achieved with tight glycemic control. Another screening test is termed the palm print sign. Ink is applied to the hands of a patient, who is then instructed to press his or her hands onto a piece of paper on a table. In grade 1, all phalangeal areas are visible. In grade 2, you cannot see the interphalangeal areas of the 4th and 5th fingers. In grade 3, you cannot see the interphalangeal areas of the 2nd to 5th fingers, and in grade 4, only the fingertips are seen. Diabetic stiff joint syndrome is important because there is reported to be an association between that manifestation and difficult intubation. Up to 1/3 of patients with long-standing type 1 diabetes are reported to present some degree of difficulty on laryngoscopy. This is generally attributed to limited mobility, most commonly of small joints, due to deposition of glycosylated collagen in the joints. There is reported to be an association between difficult intubation and a positive prayer sign. Other factors predisposing to difficult intubation include limited atlanto-occipital joint mobility and something called scleroderma of diabetes, which constitutes woody, non-pitting edema of the posterior neck and upper back. In a single study of 60 patients with diabetes, the palm print sign was described as being 77% sensitive and 89% specific in predicting difficult intubation. None of the other tests evaluated, including the prayer sign, modified Mallampati exam, or measurement of thyroid mental distance, or assessment of neck extension, was as effective in predicting difficult intubation. This concludes part 2 of my podcast on diabetes. Good luck on the exams. This is part one of my video cast to address keywords and phrases relating to diabetes. The keywords and phrases have been extracted from several years of in-training exams. As usual for my presentations, there will be very few slides containing solely words. Most will consist of illustrations, tables, or graphs to emphasize the points. It might be worthwhile for you to pause the presentation on some of the slides which present significant detail. These are the keywords related to diabetes that will be addressed. The phrase in red, diabetes and stiff joint syndrome, was a new item in 2017. The first keyword is the perioperative effects of insulin. I have racked my brain trying to figure out what kind of question could be written based on this keyword. The fact is that insulin acts the same way in the perioperative period as it does any other time. Here's a list of some of the more prominent actions of insulin. The next thing that occurred to me was that the question might be related to insulin resistance, which is known to occur as a consequence of increased cortisol and catecholamines associated with surgery. This slide lists some effects of insulin resistance. Note that the increase in procoagulant factors is a result of hyperinsulinemia and is not a direct effect of insulin resistance itself. Of these effects, the effect on nitric oxide is the most interesting from the perspective of anesthesia. Eventually, I decided to address the keyword from the perspective of the surgical stress response. Stress, including that imposed by surgery and anesthesia, stimulates a cascade of responses. From the perspective of glucose control, most of these result in an increase in blood glucose. The increase in catecholamines results in a decrease in the release of insulin and an increase in the secretion of glucagon, both of which will result in an increase in serum glucose. Additional factors in the stress response include an increase in the release of cortisol and growth hormone. Cortisol increases hepatic glucose production and promotes gluconeogenesis. In addition, the combined effect of the stress response is to increase free fatty acid production. Increased levels of free fatty acids inhibit glucose uptake by the cells. The combined effects result in an increase in glucose production, a decrease in insulin release, and a relative resistance to insulin. This is the next item on the keyword list. There are at least three ways to view this keyword. The most obvious is to consider the complications of diabetes, both microvascular, for example retinopathy, and macrovascular, for example peripheral vascular disease. Diabetes is the leading cause of end-stage renal disease and adult blindness. It is also the leading cause of lower extremity amputations. It has been reported that the surgical mortality rate in patients with diabetes is 5 times that of patients without diabetes. This approach seems too obvious. The second approach would be to consider the direct effects of hyperglycemia, which may be the point of the question. The third approach would be to consider the complications associated with severe, acute hyperglycemia, for example diabetic ketoacidosis. At one point in time, hyperglycemia was considered advantageous for critically ill patients. The belief was that it provided an additional substrate for energy production. Subsequent work has documented that hyperglycemia is an independent risk factor for perioperative morbidity and mortality. Hyperglycemia is associated with a decrease in nitric oxide production and release, which leads to vasoconstriction with a consequent potential for compromised blood flow. It is also associated with a decrease in complement function and neutrophil chemotaxis and phagocytosis. The end result of these changes is to increase inflammation, increase vulnerability to infection, and increase the risk of multi-organ system dysfunction. The final approach is to consider the implications of severe acute hyperglycemia. Hyperglycemic hyperosmolar non-ketotic syndrome primarily occurs in conjunction with trauma or infection in patients over age 60 with type 2 diabetes. It is the initial presentation of type 2 diabetes in some patients. Generally speaking, the problem develops over weeks during a period of stress, for example in the presence of an infection, with a persistent diuresis due to glycosuria. Although ketones are not formed due to continued secretion of insulin, a lactic acidosis may occur due to hypoperfusion. Mental obtundation or coma may occur due to hyperosmolarity. Vascular occlusion may occur due to low flow states. A good question about HHNS or DKA would be to ask about specific lab values in the two conditions. One thing not listed in this table is that serum electrolytes tend to be normal in patients with hyperglycemic hyperosmolar non-ketotic syndrome. In the presence of DKA, patients will tend to have hyponatremia and hypophosphatemia, and magnesium will have a tendency to be low. In the presence of lactic acidosis due to hypoperfusion, the values listed for pH bicarb and anion gap for HHNS may resemble those of DKA. Treatment of DKA is the next subject to be addressed. In addition to asking about the treatment of a patient with DKA, good questions would include inquiring about the etiology and assessment of DKA. From this slide, it should be evident that 1/3 of cases of DKA are due to mismanagement of the patient's insulin, and almost equal number are due to the presence of an infection. Patients with DKA generally have an increased anion gap acidosis. I want to duly note that I despise the concept of the anion gap. I don't like it first because the very word gap tends to imply something abnormal. With that in mind, how can you have a normal gap? Second, I don't like it because there are two ways to calculate the value for the anion gap, with and without potassium. Finally, I don't like it because there are two different values for normal, depending on which formula is used for the calculation. Because the metabolic acids are not used in the calculation of the anion gap, ketoacidosis is a high anion gap metabolic acidosis. Just to be clear, diabetic ketoacidosis results in an increased anion gap, even if potassium is used in the calculation. Patients with DKA also commonly are hypotensive and tachycardic, with some form of spontaneous hyperventilation. Small breathing consists of tachypnea with large tidal volumes and is associated with a metabolic acidosis. Diabetic ketoacidosis is one of the most common causes of small breathing. As noted on a previous slide, hypomagnesemia is a relatively frequent finding in patients with DKA. The etiology of hypomagnesemia in these patients includes pre-existing conditions such as poor dietary intake or increased gastrointestinal losses secondary to autonomic neuropathy. It may also be due to increased renal losses due to the osmotic diuresis or a shift of magnesium into the cells, like potassium, with insulin administration. A prolonged corrected QT interval, QTC, is the most common ECG manifestation of hypomagnesemia. Evaluation of a patient's cardiac status is also relevant in the presence of DKA, although this slide demonstrates the increased risk of major vascular complications in patients with type 2 diabetes. It is useful to demonstrate the increased risk of acute myocardial infarction. DKA is associated with myocardial infarction either before the onset of DKA, since acute MI is described as the precipitating event in approximately 4% of cases of DKA, or during the episode, since DKA may result in increased myocardial oxygen demand, at least in part due to the increases in catecholamine output associated with acidosis. One word about serum sodium in the presence of increased blood sugar. Hyperglycemia results in a decrease in serum sodium of 1 milliequivalent per liter for every 62 milligrams per deciliter increase in blood glucose. This occurs as fluid is drawn from the cells into the intravascular space due to the osmotic effect of glucose. Accordingly, most patients with DKA will have a low serum sodium. It's important to remember, however, that the total body sodium will be normal. Some patients with DKA may present with